So, with all of these payment structures and delivery structures, there's a lot of change. In transitioning to value-based care, this amount of change represents a large challenge. And there are a number of challenges that need to be overcome for success. Each of the topics identified as needs are topics we list here and then expand on in subsequent lectures. The topics are broad and address virtually every aspect of healthcare payment and delivery. In an earlier lecture, we described the transition to value-based care as a transformative change, and indeed it is. But we also saw that the quality and cost issues associated with healthcare in the U.S. were immense. Not included in that discussion were issues to be addressed during the transition period, which are also large and challenging. These include the fact that the U.S. healthcare delivery system is essentially facing growing numbers of baby boomers who are living longer and are increasingly consumer-like in their approach to healthcare. The cost of care for boomers will tax the Medicare system to the limits and require significant levels of innovation to improve quality and reduce cost. As Gen Z become adults, their connectedness and expectations for immediacy will continue to reshape healthcare, as we alluded to earlier in identifying the potential demise of primary care physicians. These factors alone could be the driving force behind value-based care, not just the overarching quality and cost issues previously described. So we will focus on areas that need to be addressed as soon as possible so that the transition to value-based care cannot only be successful but will occur in as timely a manner as possible. Our first focus area will be on leadership, which is needed at every level of the health system for value-based care to be successful. In fact, a lack of leadership at any level could easily derail strides made so far. Clearly, financial administrative management requires new competencies in understanding the total cost picture and as revenue drops, optimizing margins through improving operating costs and quality, neither of which have been the domain of those financial administrative managers. Operational improvements such as improving performance, streamlining workflows, and reducing waste are not typically the domain of clinical staff, who make up the bulk of the workforce being relied upon to keep healthcare afloat. The U.S. has addressed some aspects of improving technical infrastructure through the incentives for meaningful use of EHRs, although use of EHRs remains on the list of physicians' most hated aspects of their work. We must get a handle on the data collection burden for quality measurement and reporting. Likewise, we must rapidly get up to speed with analytics skills so that we can make better use of the cost of care and quality measurement data we are collecting. We have also not done well in addressing interoperability issues. Likewise, population health and health consumer roles are generally not top of mind for providers when presented with a life-threatening medical event, nor really any medical task. As providers and even health plans try to equip themselves with the skills needed to address current issues, Health 2.0, which was use of social media, mobile technologies, cloud computing, and user-generated content, is now moving to Health 3.0. On the cusp of Health 3.0, the health industry is looking at new business models such as Amazon, JP Morgan Chase, and Berkshire Hathaway forming a healthcare company, and CMS and Aetna, without its Part D prescription drug plan business, merging. There is new focus for medicine on relationships, such as coordination of care across the entire continuum of care, integration of mental and physical health, traditional providers working with social services and public health, providers using patient-reported data, and even the line between providers and health plans blurring could easily put health professionals who generally are slow to adopt change really over the edge, so to speak. But you are attending this MOOC because you are ready to take on these challenges. So as in all lectures, the references listed in this and the next slide were used in compiling this lecture. Perusing the list even without activating the links is a good way to identify the major thought leaders in the topics we've covered. Thought leaders often include professional associations and societies, major vendors, and of course federal government agencies. In this list of references, you will find links to the most current CMS information on bundled payment and MIPS as of 2018 October. It is important to remember that CMS makes changes every year and that changes are initiated with a proposed rule, usually issued in July or August, followed by finalization of the rule, sometimes as late September.